Hi, everybody. Good evening, good morning, good afternoon. It is 6 p.m. in Paris, 6 p.m. in Amsterdam, 5 p.m. in London. And it is my great pleasure and honor to welcome you all to this special ICH Springer Healthcare IME educational webinar dedicated to managing toxicities in relapse refractory multiple myeloma. And this is going to be based on expert-led case discussions. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And I'll be joined today by two superb top experts in the field of multiple myeloma, namely Professor Yong from University College London in the United Kingdom, and Professor Niels van de Donk from the Amsterdam University Medical Center in the Netherlands. This is a very high-level educational activity, so we have clear learning objectives, and we hope that after participating in this webinar, you'll be able to identify and explain toxicity issues associated with new treatments for relapse refractory multiple myeloma. You'll be able also to discuss the strategies for the mitigation and management of toxicity issues associated with new treatments for relapse refractory multiple myeloma. And last but not least, we would like to help improve clinician-patient communication to encourage shared decision-making in the management of multiple myeloma. So you can see the agenda of this roughly 1 hour webinar. We will start with Dr. van de Donk about a case discussion on how to manage adverse event with monoclonal antibodies. As you probably know, these days, anti-CD38 monoclonal antibodies are the most popular ones. Then we'll have Professor Kwee Yong, who will present a case about the management of adverse event with antibody drug conjugates. And we do have an excellent approved antibody drug conjugate in multiple myeloma, namely belantamab. And then at the end, I'll present a case of a CAR T cell treatment and how to manage adverse event. During the whole webinar, you will be able to post your questions using the Q&A or the chat. And either questions, comments, suggestions, if you would like to contribute to what's being discussed by the speakers and the panelists, please don't hesitate. This is meant to be highly interactive. So you can see it here. You can interact by answering also the polling questions that I'll share with you in a few seconds. Please don't forget that you have to exit the full screen mode if you want to participate in the poll, and polling will be on the right side of the screen next to the video. But I'm sure these days everybody's familiar, with these tools. And of course, please don't forget to complete the evaluation form at the end of this symposium. As a disclaimer, we do have an unrestricted educational grant from GSK. So, as I mentioned, we have pre and post-assessment questions. So I'll ask you a few questions before we start. You'll have to answer, and then we'll ask the same questions at the end, and we'll share the answers with you at the end. So my first question, which is a more general question, as you may guess, is about how confident are you in your ability to manage treatment-related toxicities in patients with relapse refractory multiple myeloma. You can tell there's no right or wrong answer, guys. You can be very confident, mostly confident, moderately confident, slightly confident, or not confident at all. Obviously, it's a bit subtle, to see what's the difference between moderately or slightly or mostly, but I'm sure you got it. And the idea for us is to have a picture about, where does the audience stand when it comes to this topic. So please vote. I can see half of the participants voted. I'll give you another couple of seconds, maybe. Okay, so we'll close the polling. It looks like that only a very limited number of colleagues are very confident, which is quite logical because the treatment we will discuss are brand new actually, and it takes some time. There is a learning curve, but I'm glad to see that there is a lot of people who are mostly or moderately confident. My second question for you now, this is the real business, guys. So during second-line treatment with daratumumab, lenalidomide, and dexamethasone, the famous Dara-Lendex, Pollux trial or Maya trial, or actually here it's in relapse, so second line, Pollux. So gradually reducing dexamethasone is likely the most appropriate management strategy if a patient develops diarrhea, if a patient develops sleeplessness or edemas, or a patient experiences fatigue. Remember, there's only one good answer, because obviously maybe all of them are correct, but we're asking which is the most appropriate, guys. Please vote. And I think the audience now is becoming quite motivated because they can see the voting screen moving rapidly. Excellent, fantastic. We'll figure it out because not everybody got it right, guys. Okay, we'll figure this in a few minutes. Question number 3. Okay, now remember, which of the following statements is false? We need to get the wrong answer, guys. So, when it comes to managing CRS, cytokine release syndrome with CAR T cell, high-dose corticosteroids can be recommended. Tocilizumab can be recommended, and antibiotics are mandatory. This should be an easy one, guys, but who knows? Okay, and please don't forget, read the question correctly. We need the false statement, the wrong one, not the good one, because at least 2 are good, actually. Okay, wonderful. Wow. Yeah, I think the majority are getting it right. Let's give them a couple of seconds to answer. Fantastic. The cursor keeps on moving. Excellent. Wonderful, wonderful. Great. Okay. Now it is my great pleasure and honor to introduce Professor Niels van der Donk, who is a professor of hematology at the Department of Hematology in Amsterdam, at the Free University of Amsterdam. I'll avoid pronouncing it in Dutch. Vrije Universiteit Amsterdam. Apologies if I'm totally destroying the beautiful Dutch language. And he will present a case discussion on managing adverse events with monoclonal antibodies. And you can see these beautiful photos of the beautiful canal and houses of Amsterdam. I have my collection from the KLM flights, of these houses. Okay, Niels, the floor is yours.
Yeah, thank you so much, Mohamad, for your kind introduction. Here you can see my disclosures. And in this slide, you can see that in the Netherlands, the survival of myeloma patients has improved substantially over time. And of course, this is not only true in the Netherlands, but this is true across Europe. So in the 90s, this was due to the introduction of transplant. Later on, the IMiDs made a big change, the proteasome inhibitors as well. And more recently, you can see that also the monoclonal antibodies, next click, have really contributed to a better progression-free and overall survival. So that's the SLAMF7 targeting antibody elotuzumab and the CD38 targeting antibodies daratumumab and isatuximab. So today I would like to discuss the management of toxicities that can be associated with regimens that contain a CD38 targeting antibody. And I want to discuss this based on a patient from my clinic. This is a lady who was diagnosed in another hospital in February 2013 when she was 67 years old with multiple myeloma. She had bone lesions, she had a paraosseous plasmacytoma, cytogenetic risk at that time was not assessed. And she started in that other hospital with melphalan, prednisone, and bortezomib in 2013, and she achieved a very good partial response. She had some neuropathy for which we had to dose reduce bortezomib. And unfortunately, already after 1.5 years after starting this treatment, she had her first relapse with new bone lesions and a rapid increase in M protein. And at that time, she was 68 years old. She was treated rapidly with radiotherapy because of a large mass, a large paraosseous plasmacytoma that caused pain. And of course, we had to think about starting a second-line systemic treatment. In this diagram, you can see that when you are thinking about second-line treatment of first relapse, you have to take into account various factors, patient characteristics, for example, presence of comorbidities and the patient's preferences. You have to consider tumor characteristics such as cytogenetic risk and the speed of progression. And maybe most important when selecting a relapse regimen is type of previous therapy. Was there a response? Was there a toxicity? And of course also, and this is different in all the different countries, reimbursement and availability issues. Our lady had not been exposed to lenalidomide, and on the lower left you can see that lenalidomide patients that have not been exposed to lenalidomide can be treated very effectively with a lenalidomide-based triplet regimen. And we prefer in fit patients triplet regimens over doublet regimens because they are associated with higher efficacy, better response rates, higher rate of MRD negativity, and this translates into better PFS and also OS in various of the studies. Maybe one slide back. So there are several len-based regimens available for our patient, and this is daratumumab lendex, elo lendex, carfil lendex, and ixa lendex. And the best regimen, as we know now, in terms of progression-free survival advantage, is the regimen of lendex with the CD38 antibody. Very briefly, on the right, you can see some regimens with Velcade and carfilzomib and pomalidomide, which can be used in patients that are len refractory at the time of first relapse. So then what to do with our patient that was len naive, not exposed to lenalidomide? Well, in 2014, we had in our center the Pollux study open. This was a phase 3 study that randomized patients with at least one prior line of therapy to either lendex, which was the standard of care by then, or patients could receive daratumumab lendex. And the good thing was that our patient, our lady, was randomized to daratumumab plus len plus dex, the triplet regimen. So what type of things do you have to consider when you start a new patient on daratumumab or another CD38 antibody like ISA? Well, I have marked these aspects in the red boxes. One of the things that is important to realize is that antibodies can result in infusion-related reactions, especially when you give the antibody for the first or second time, and therefore we give patients appropriate pre- and post-infusion medication to reduce the risk of infusion-related reactions. So we give our patients dexamethasone or another steroid. We give them paracetamol, an antihistamine, and I also give my patients, before the first infusion of a CD38 antibody, montelukast, a leukotriene antagonist, and this whole cocktail prevents development of infusion reactions and respiratory reactions. So that's important. Also important when you start treating a patient with a CD38 antibody is that you realize that CD38 antibodies interfere with blood group testing in the laboratory. So CD38 is also expressed on the red blood cells in the test tubes in the lab, and therefore you get some interference with blood transfusion testing. And therefore, before I start giving a patient daratumumab or isatuximab, I perform some additional tests so that I'm well prepared if the patient needs a transfusion later on. So I perform serotyping for clinically relevant antigens before starting daratumumab, or when the patient has recently received red blood cell transfusion, I perform genotyping. And genotyping is also possible during daratumumab or isatuximab therapy, while serotyping is not. So this is important before you start, and then when you are, and other aspects that are important during daratumumab therapy are shown in the next slide, and that includes, well, one of the aspects that is also important during daratumumab treatment is that the therapeutic antibody can be seen in a SPEP or IFE assay. So the assays that are used to assess the level of the M protein of the patient. So daratumumab, isatuximab, elotuzumab are also antibodies and can be seen in these assays. And that can be difficult because it may interfere with the assessment of complete remission. And this is especially important, of course, in clinical trials, where you really want to state if the patient has achieved CR or not. And then you can use different assays like the DARA shift assay or mass spec assays to be able to see if the endogenous M protein of the patient is disappeared or is still present. Other aspects, of course, are giving our patients the appropriate prophylactic drugs. And when you put a patient on dara-landex, I think it's important to start thrombosis prophylaxis with aspirin or LMBA, low molecular weight heparin. You have to start infectious prophylaxis. I give my patients herpes zoster prophylaxis with acyclovir in this regimen. And I also give my patients cotrimoxazole to prevent respiratory tract infections and PGP. And I give my patients a proton pump inhibitor. So our patient started dara-landex 7.5 years ago, and after 1 or 2 or 3 cycles, she developed some complaints of sleeplessness and also edemas, and this is probably caused by the dexamethasone in this regimen. So I gradually dose reduced dexamethasone to 0, so I stopped it after a while. Our patient also developed diarrhea, and this was probably caused by lenalidomide because it's well known that lenalidomide induces malabsorption of bile acids, and these bile acids can then induce in the large bowel secretory diarrhea. And this can be perfectly well managed with bile acid binding sequestrants like cholestyramine. They bind the bile acids, and this leads to resolution of the diarrhea. Our patient also experienced some fatigue and eventually worsening of diarrhea, and that made us dose reduce lenalidomide. Eventually, we had to stop this agent. And in the next slide, you can see that she's still on daratumumab at this moment. Daratumumab is now giving every 4 weeks. And in fact, in April 2022, we were able to change IV daratumumab in the POLLUX trial to the subcutaneous administration, which is much more convenient for the patient. And you can also see in the graph that this patient achieved a very deep remission. In fact, she achieved a complete remission, a stringent complete remission, which persists until now. So her second remission is lasting from 2015 to 2022 July, 7.5 years, and maybe even longer because she's still not relapsing, while her first remission was only 1.5 years. And I think this is something that we now see more and more with the introduction of very effective drugs, novel drugs in relapse regimens. So better remissions during relapse than during upfront therapy. So in conclusion, when you manage a patient on daratumumab, don't forget the blood transfusion testing so that you don't get into trouble when you have to give a transfusion, because then it takes much more time to arrange everything. Before you start treatment, give the appropriate pre and post medication to prevent infusion reactions, prevent thrombosis and infections with appropriate prophylaxis. Consider the DARA test if you want to assess for CR, if the M protein and daratumumab are overlapping. And I think very important with all regimens that we give to our patients is to timely dose reduce the different components of the regimen to avoid treatment discontinuation because of adverse events. Because when you have to stop everything, that has a negative impact on response and response duration. Thank you for your attention.
Thank you very much, Niels, for a lovely case, and actually congratulations. I mean, 7.5 years of CR in relapse, while, you know, at diagnosis, the results were much less appealing. This is really highlighting the great advances we've seen in multiple myeloma. So guys, don't worry, I'm seeing your questions and I'm taking notes. They are in front of me here, the questions. We'll have a sort of roundtable discussion, but before switching to the next case, I would like to kindly ask Professor Yong, what were her thoughts about this case, and whether in London, do you use the same approach as nicely described by Niels when it comes to whatever prophylactic measures, pre-medication? Are there anything is different in the UK?
Thank you. That was a great case, Niels. And again, congratulations. Actually, our longest surviving patient on the Pollux study, interestingly, is just on Lendex. So that is something else, you know. There's always the unexpected around the corner in myeloma, isn't there? But coming back to daratumumab and dara-Lendex, I'm interested that you withdrew and eventually stopped the lenalidomide. That is something that we have sometimes done, and you're right, I'm always more inclined to stop the lenalidomide than to increase the interval between the infusions of the antibody. And stopping the dexamethasone is something that I find more and more really helps the fatigue with daratumumab. So when patients complain the antibody makes them fatigue, actually it's the dex, it's the steroids. So that is one learning point after years of using the antibody. But I agree with the prophylaxis, we do exactly the same with prophylaxis. Tell me, did your patient have any infections, any opportunistic infections, chest infections?
Well, that's a good question. We have to be aware of infections with all these immunotherapies that also have an impact on normal immune cells. And we, of course, see some hypogammaglobulinemia in our patients treated with such regimens. But this patient has no major events of infections, no more than you would expect from other, well, I think she's now 75 or 76 years old. So she has no profound infections. So she's not an IVIG, if that's your question. Because when you have, of course, a patient with recurrent respiratory tract infections, the suppletion of IVIG, polyclonal immunoglobulins, can be very helpful to consider.
Yeah.
But she's almost 75 now, I think, based on, which is really great. Okay. Let's now move on to the next case by Professor Yong, and Kwee, you can share your slides if you wish.
Here are my slides. Can you see this?
Yes, absolutely. This is perfect.
I'm Kwee Yong. I work at University College London, and I'm going to go straight into this case, which is a case of a patient treated with an antibody drug conjugate. Here are my disclosures. So here is my patient. My patient was diagnosed with kappa light chain myeloma in July 2005. So this was a long time ago. And at this time, we were doing FISH, but the FISH was normal. Patient had ISS2 disease, but also already diagnosed at diagnosis, had a constellation of comorbidities, hypertension, had ablation for atrial flutter. This was much later on in 2017. So the cardiac complications came later on in the history, I beg your pardon. But when the patient was first diagnosed, we were at the time using an oral regimen of idarubicin and dexamethasone. The response was clearly suboptimal, so we escalated with ESHAT, which is an infusional chemotherapy, and then the patient had a transplant. We were running a consolidation study with cyclophosphamide, dex, and thalidomide, and the patient received 8 cycles of this. When the patient relapsed, they were retreated with PAD. They were treated with PAD, so that's Velcade, Adriamycin, and dexamethasone for 4 cycles, and received a second transplant. At the next relapse, the patient went on to the ELOQUENT study, which is elotuzumab, lenalidomide, and dexamethasone, and you heard Niels talk about elotuzumab, which is a CS1 targeting antibody. And then the patient relapsed again, and this time was entered onto the CANDOR study, received carfilzomib, daratumumab, and dexamethasone, so a CD38 antibody. On relapsing from that, received pomalidomide, cyclophosphamide, and dexamethasone. So you get the picture that this patient was able to respond again to the next line, and on relapsing was fit enough to receive what are triplet regimens ever since the first relapse. So here you have a patient with pentaclast refractory myeloma, who by this time is quite frail, because through this whole history and relapsing, the patient had actually undergone some cardiac events, had an ablation, had a non-STEMI, and then had cardiac bypass ×2. So by the time the patient comes to us, and this case, I have to point out to you, is a case from Dr. Rakesh Popat, but I couldn't resist using it because, as you can see, we actually took this patient through a study with belantamab. At the time, we were running a single agent phase 1 study with belantamab. And this patient is a very good illustration of how you can manage the toxicity. So let's start with October 2019. We meet this patient now, he's 66. He's got pentaclast refractory IgA myeloma, and we start treatment with 2.5 mg per kg of belantamab. This was on a 3-week cycle. At the start, he had an infusion reaction, as we would expect, and as often with patients at relapse, they have a respiratory tract infection or some kind of infective complication. At the second cycle, he developed grade 3 thrombocytopenia mid-cycle, but no ocular AEs. So then he went, and then at the start of cycle 3, and important to note that an eye examination was done pre-start and at the start of each cycle. So by the time he reached day 1, cycle 3, his thrombocytopenia had recovered. He was asymptomatic from the point of view of ocular symptoms, but when tested, had a grade 2 reduction in visual acuity and had grade 2 moderate punctate keratopathy on ophthalmic examination. At the time, we held treatment and we continued and gave him eye drops. In cycle 4, by this time, he'd made just an MR. He had no AEs apart from ocular AEs. His grade 2 keratopathy, he had grade 2 keratopathy, but his visual acuity had improved to grade 1, so we were able to continue the belantamab. But he came to the end of the year, and in January, early January, he was admitted with a community-acquired pneumonia, and coronavirus, but non-COVID-19. Later on that month, he recovered, and we assessed him for cycle 5. At this time, he had a grade 2 reduction in visual acuity, grade 3 keratopathy, and we held the treatment, and we continued to give him eye drops. In the next cycle, again, he still had grade 2 reduction in visual acuity with grade 2 keratopathy, and we held the treatment again. So you can see from starting in October 2019 till February 2020, he only received 3 doses. So what happens then? At cycle 7, again, we had to hold treatment because of the grade 2 reduction in visual acuity, but he also started getting visual acuity problems in the right eye, in addition to the left eye. At the next cycle, his visual acuity problems had reduced to grade 1. He has still had keratopathy, but grade 1, and so we were able to restart treatment at a lower dose of 1.9 mg per kg. In the next cycle, we were able to continue treatment, although he still had grade 1 ocular toxicity. You will note throughout here that actually he had no other toxicities, no other AEs, they were all ocular. For the next 3 cycles, we had to hold treatment. We had to hold treatment because he continued, he developed grade 2 keratopathy in both eyes, and the visual acuity in the left eye worsened to grade 2. And you will see that his visual acuity, either in the right eye or the left eye, was at grade 2, and he also had grade 2 keratopathy. So really, over this period of time, he had only half the cycles that he was planned to receive. And by the autumn of 2020, his ocular symptoms and AEs had reduced to grade 1, so that we continued belantamab for another 2 cycles. He had reached a PR, but sadly he progressed, and we stopped treatment in September 2020. This patient actually remained well, and his only problems were ocular problems and a reduction in visual acuity, which affected watching television. So the learning points from this case are that if you monitor eye toxicities carefully and withhold your dosing, you can actually maintain patients on treatment for a good period of time, maintaining the response. Now, this patient, unlike some other patients we've treated with belantamab, did not ever achieve a deep response in terms of VGPR or CR, but he maintained the response over a long period of time with actually relatively infrequent infusions of belantamab. We need to remember to undertake prompt dose reduction or omission. He achieved a response at cycle 5, and he was able to sustain this for 9 months despite interruption of treatment. And for a patient who's penta-refractory, having received so many lines of treatment and quite intense, and having failed really quite intense triplet therapies, the response and the maintenance of the response with single agent antibody, I think, is remarkable, and disease control over 12 months.
Thank you very much, Kwee, for again another very interesting case. And I was impressed actually by the number of conventional chemotherapies that this patient has received initially. I mean,
this was a professional trials patient.
Yeah,
many trials, yes.
Absolutely.
Yes.
So, Niels, what do you think?
No, I think this case was very well illustrating the management of belantamab mafodotin. Maybe, can you still hear me?
Yes.
Yes, absolutely.
Okay, because Kwee is frozen for me. I think this case very well illustrated how to manage belantamab mafodotin and the ocular toxicities that are common. Maybe one question to Kwee, what type of eye drops did you use? Because I think there was a small trial, part of the
Yes.
DREAM studies, in which they gave the patients corticosteroid eye drops in one eye and not in the other, and that it did not make a difference.
No, that's right. So
I think please go ahead.
At this time we were using saline eye drops, but I do remember the trial of comparing the dexamethasone eye drops in 2 eyes, and they didn't make a difference. Do you use eye drops in your belantamab treated patients?
Yeah, we use the artificial tears,
yes.
like Dura tears or equivalent type of drops, but no steroids anymore.
No, we don't either.
Yeah, and maybe interesting, you show how effectively you can space belantamab mafodotin, and this is now also evaluated, right, in the combination strategies, for example, with Lendex in upfront setting or with Pomdex. Maybe it's better to have larger intervals between the 2 infusions to prevent and reduce ocular toxicity with belantamab.
I think so. And now we are using it on compassionate basis, compassionate access. We're actually using it at least an interval of 4 weeks, if not 6 weeks, really.
Okay.
Yeah.
No, I think this is really very important, because initially there was this rumor, with the antibody drug conjugate and belantamab, that this is going to be very dangerous because all patients are going to become blind, which is absolutely untrue. We're talking about keratopathy. It is reversible. And I think now with the learning curve from many teams, and I think in the UK you use it a lot, we know that if you space it more between 2 cycles, you allow the regeneration actually in the eye. And because these antibody drug conjugates are backbone in hematology, we can't simply just ignore them because we're excited about something else. We know in ALL, in AML, in Hodgkin lymphoma, and I think the data, by the way, Kwee, we heard during the last EHA from Ivan Cholosterpos using in the elderly frontline. The safety was quite appealing. What did you think about these data, by the way?
Yes, I was struck by 2 things. I was struck by the initial high incidence of ophthalmic morbidities already in an elderly non-transplant eligible group. At something like 80% of patients had cataracts, and another quite a few, about 30% patients had fundoscopy abnormalities. So that was one thing. And the second thing was actually the very low the lowish incidence of grade 3/4 ocular toxicities. And this was, I think, the optimal. They selected eventually an 8-week interval with a belantamab dose of 1.9 mg/kg, which so that looks really promising in the frontline setting, doesn't it, in conjunction with Lendex?
Absolutely. And by the way, one question to you, Niels, from Dr. Salinas Rodriguez. Can you combine belantamab actually with an anti-CD38? Do you have such experience?
I think studies are planned or maybe already started. So we have no experience with that combination, but from a mechanistic point of view, I think it's a very interesting combo to target both BCMA and CD38 at the same time. But I think there are no results of this combination yet available.
Yeah, absolutely.
And can I ask one question to Kwee,
Mohamad? Please.
So this patient was quite young still, no? When he relapsed after belantamab mafodotin, and he was at that moment refractory to Len, Pom, carfilzomib, daratumumab. So were you able to treat him in another trial, for example, with the bispecific or CAR-T?
Yeah.
Or what happened?
Yeah, I don't think we know what happened to this. I personally don't know what happened to this patient. He actually remained in PR for quite a while, and then we tried to get him onto another trial, but we ended up giving him cyclothaldex for a little while to hold him. But I can't remember what happened to this patient. We had very many of these patients, but yes, very well.
It will become, one of the open issues is still the best sequence, right? When we have belantamab mafodotin, BCMA CAR-T, BCMA bispecific approved, what will be the best sequence? Do we need a washout? So this is also something that's very actual and will be answered in the upcoming meetings, I hope.
Thank you. But I can tell you he did not receive a CAR T, that's for sure.
Okay.
Well, okay, that gives me a good transition, Kwee, because then I'll share with you the case of a patient we managed and who received CAR T-cell. So these are my disclosures. So you can read the history of this patient. His story started in June 2012. And at this, so this is free kappa light chain myeloma. So at this time, the standard induction was VD, bortezomib dexamethasone. He received an auto with MEL200, achieved PR, and then consolidated with VRD, achieved the VGPR. And actually, in 2012, there were no recommendation to give LEN maintenance, so he didn't receive maintenance. But he stayed actually in VGPR for 2 years, actually, until September 2014, where the disease progressed. So actually, he was restarted on VRD and achieved VGPR again for almost, 1 year and a half. The disease progressed again. He received carfilzomib Lendex. This is the Aspire trial, 2 cycles. But then he didn't tolerate it, I think. He wasn't followed in my department at this time. He didn't tolerate the carfilzomib, so he was, after 2 cycles, so he was switched to pomalidomide, cyclophosphamide Dex, PCD, and he achieved another VGPR. And at this time, given the limited option in 2016, and he had a second graft, so he went into a second auto, followed by PomDex maintenance, because he looked like to be very sensitive to IMiDs. Things remained okay for 1 year. October 2017, another progression. And by this time, he could have access to Dara-Lendex, but only PR. But given all of the different treatments he accumulated, especially double auto, this problem, especially that also he received bendamustine and prednisone at the institution where he was followed, he developed some pancytopenia and needed transfusions. Still, he managed to make it from for another 3 months. Venetoclax, although he wasn't translocation, he didn't have the translocation 1114, was tested. He was able to receive a few months of ixazomib, a few weeks of ixazomib, only PR. So in May 2018, his local physician said, well, supportive care, we've tested everything. And by this time, he didn't have access to elotuzumab, actually, because that was the possible option, but he didn't get access to it. So this is where, when he was referred actually to CAR T-cell, and he received an academic CAR T-cell infusion on the 31st of July, 2018. So that was the schema of administration, nothing special. He actually received fludarabine cyclophosphamide for lymphodepletion, and then got his CAR T-cell infusion. So just to give you an idea about his disease, before the CAR T-cell infusion, he had quite high serum of light chain kappa, and he had a huge proteinuria, more than 90% malignant plasma cells infiltrating the bone marrow. So this is the evolution of the temperature and the arterial tension, of this patient. So this is real world, now everything is electronic, but at this time it was still on paper. And you can see that less than 24 hours, roughly, actually, a little bit less than 24 hours after the CAR T-cell infusion, he developed hypotension and also high fever, more than 40 degrees. And by this time, remember, we are in 2018, so that was the grading being used for symptoms and signs of CRS. And you could see that he was probably somewhere here between grade 2 and grade 3, because he had the fever. He didn't need high dose vasopressors, low dose, but responded to IV fluids, but definitely had a grade 2 of these symptoms, especially when it comes to the cardiac symptoms. I cannot guarantee that it was like grade 2.5, between grade 2 and grade 3. And actually, that was very concomitant of a very impressive proliferation of his CAR T cells. All of this phenomenon, you can see, for instance, by day +3, that this was the proliferation of his CAR T cell. By day 4, it continued to proliferate, and actually later you can see he achieved up to 35% of circulating anti-BCMA CAR T cells. So there was a logic, between the CRS and this quite impressive proliferation. So I think even today, 4 years later, when it comes to assessment and management of CRS, the SOP, although they may vary from one institution to another, but this is about assessing and closely monitoring the vital signs, control for oral and intravenous fluid input and urine output, body weight, of course, physical examination, blood counts, CRP and ferritin levels are very important, and at least even today we do assess CRS, although now there is a learning curve, I think, when it comes to CRS assessment and neurotoxicity. Well, actually, he was treated with one injection of tocilizumab, and he went very well. And you can see here the evaluation of his disease. Very impressive, where disappearance of the plasma cell infiltration very quickly, and actually he achieved complete remission. And he stayed in a good shape, actually, roughly for more than a year before the disease started to progress again. So I'll stop here, and now we'll open this for our general discussion for the next 10 minutes with also the several questions we received from the audience. I need to tell our audience that we have received a lot of questions, for instance, about also management of toxicities after bispecific antibodies. Unfortunately, this is not part of the program today, because otherwise that will take us for another couple of hours, but we will have a dedicated IACH webinar to this, guys. So please stay tuned. So Niels, Kwee, what did you think about, did we do things right in this patient, or would you have done it differently when it comes to CAR T cell management?
No, it sounds, I'll go first. It sounds as if we did it perfectly. And I was interested in the flow plots for, when you gated the lymphocytes and you had the CAR T cells, there was a very large population of monocytes, neutrophils. So clearly this is proper CRS and stimulating the myeloid population and activating the monocytes as well. So this
Actually, for the sake of time, what I didn't show you, because of course I like to learn from these first patient we do. And actually we monitored IL-6, we monitored ferritin, we monitored IL-10, interferon gamma, and all of them were going in the same direction. So I think it was a sort of an authentic
yes,
CRS.
yes, no, absolutely, absolutely. And how was the patient cytopenic? How long did cytopenia last in this patient? Perhaps you said.
Well, actually, he started recovering like after 1 month.
Uh-huh.
So probably he had some bone marrow reserve, at least some,
Yes.
residual stem cells. And as soon as we were able to get rid of the plasma cell infiltration, they started working again.
No, that's great.
So that's good news, because it means
Yes.
our stem cells are quite resistant.
Exactly, exactly. Well, congratulations.
Niels, any comment?
No, I think you did it perfectly well. I agree with Kwee. Maybe I can add that when a patient after CAR-T or bispecifics develops a fever, of course, this could be a cytokine release syndrome, like in this case, but always also consider that this patient may have an infection or a combination of CRS and infection. So you also have to do the proper anamnesis for typical symptoms and signs of infection, and do cultures, blood cultures, and check the patient carefully with the physical exam. And if you're not sure, then you can manage both at the same time. You can start antibiotics and manage CRS, and stop the antibiotics if you're sure that it's not an infection and the cultures remain negative. So sometimes we do two strategies at the same time in very sick patients.
Since we're talking about antibiotics, Niels and Kwee, we have a couple of questions about the use of antibiotics. And for instance, in your case, Niels, you mentioned that your patient, you gave cotrimoxazole. And we have a question whether you give amoxicillin, and in the UK, there was a trial about quinolones. So is there any recommendation, or it's just empirical? Despite, I think, the nice randomized phase 3 trial from the UK, it doesn't look like to me that everybody adopted this approach.
We consider levofloxacin during the first 1 or 2 cycles in patients with a history of infections, in very frail patients that you may lose when they develop an infection. So based on the UK study, we do it in a subset of high-risk patients, so not in all. So for example, my lady that I presented was not high risk. She was quite young and she had no history of infections. So we did not give her levofloxacin for the first 1 or 2 cycles, just Cotrim and valacyclovir. But we consider it, of course, in patients that are neutropenic. For example, after CAR-T, when the patient is severely neutropenic, we typically give ciprofloxacin until recovery to prevent neutropenic fever, and also fluconazole during that period of time.
Kwee?
Yes, I'm so pleased that the team study led to a change in practice with you, Niels. That's very nice to hear with the levo. We in the UK, many centres use cotrimoxazole prophylaxis. Initially, I guess ostensibly to prevent against PCP in pneumonia, but actually it also reduces the incidence of chest infections. And in fact, in the team study, the cotrimoxazole itself had also an independent effect, as well as levofloxacin. It was difficult to tease apart the two. So we use that. We use herpes zoster prophylaxis, but we don't use IVIG routinely. I'd be interested to know if you do.
No, we don't use it. I mean, at least in my center. I mean, especially now with the shortage of
Yes.
What about you, Niels?
We have no shortage, so we typically use it when the patient develops an IgG below 4, polyclonal IgG below 4, so 1.4 grams per deciliter, and especially in patients that have already developed infections despite Cotrim and valacyclovir prophylaxis. So we use it quite liberally, because after CAR-T and after bispecifics, the majority of patients develops a severe hypogamma, severe drop in IgG that predisposes to bacterial infections, pulmonary infections, but also viral infections we see a lot. And upon starting IVIG suppletion, we see a marked drop in infections in patients after CAR-T and on bispecific.
So you use the level of immunoglobulin as a threshold for putting them on IVIG? Yes.
Yeah. Or we are a little bit starting earlier if the patient has severe infections.
I see.
And hypogamma.
One question for you, Kwee, is about when you use belantamab, how frequently you would send your patient to the ophthalmologist? I mean, how frequently you do eye check, I would say.
At the moment, until we change guidance, we do it every cycle. So we do it at baseline, and then we get the eyes checked before the next dose.
Mm-hmm. And how easily can that be implemented in your clinic?
You have to cultivate a friendly and very helpful ophthalmologist and somebody who has an interest in these corneal toxicities. But once you have that ophthalmologist, you must hang on to them.
Okay.
Don't let go. Yes.
So that's your advice.
Yes. Yeah. But I think
this is quite fascinating, my friends. We'll have, because time is running, so we'll have to figure out the post-assessment questions after your lovely cases and discussion. So I would like to ask our audience now, after having heard these cases, how confident are you now with the management of the side effects? And it looks like definitely this webinar has been extremely useful because now when we look to the results, actually all attendees are now part of the group who are very confident, mostly confident or moderately confident, whereas initially we had 40% who were slightly or not confident. So this is really good news. Huh? Thank you, Niels and Kwee. You've been extremely didactic, and apparently it worked. Okay, post-assessment question number 2. And I'm sure after you heard from Niels, you know the right answer. But that was an easy one, actually. Yeah, please vote. And indeed, well, not bad, not bad. Almost 80% got it right. I think B is the most appropriate one, although, of course, fatigue, you know, can be due to many things. Diarrhea, we heard from Niels that this is mainly about lenalidomide, not such a frequent with daratumumab. Okay, post-assessment question number 3, and this is about the CAR T cell. And we had a discussion about the antibiotics, and now I think everybody got it right, 100%. Antibiotics are not mandatory, of course. And for the management of CRS, of course, tocilizumab or even anakinra are recommended, but also high-dose corticosteroids can be also recommended in some refractory cases. But I must confess that now we intervene usually very early. So this is why usually we don't see much severe CRS. And interestingly, in multiple myeloma, in contrast to non-Hodgkin lymphoma or ALL, the incidence of severe CRS and even neurotoxicity is relatively low. So this, of course, has been very interesting. I hope you have enjoyed this webinar. Please don't forget to complete the evaluation form, because obviously we need your feedback to continuously improve the quality of these webinars. And I do apologize to all the colleagues, because we couldn't take all the questions. We had also patient advocates and representatives. And thank you all for attending. And I promise we'll have other similar interactive cases, because I think this is quite popular to see the real-life management of these events. So thank you so much, Niels. Thank you so much, Kwee, for dedicating some time. I know it has been a busy day because everybody's doing this in addition to their daily work and burden. So thank you for dedicating the time, for sharing your experience, and I'm sure we will see you again in another IACH activity at some point in the near future. But in the meantime, guys, I hope you will enjoy your evening, your afternoon, your morning, wherever you are. And maybe if you're going to have some vacation in the next few days, I hope you will enjoy some rest, and please stay safe and keep well. Thank you very much.